Started.
Good morning, everybody. Welcome to our medical grand rounds. It's my pleasure to introduce first Dr. Dinesh Kalra, professor of medicine, chief of our cardiology section, and he's also the endowed chair of the Cardiovascular Innovations Institute. You all know that he's a multimodality cardiac imager, but he's also establishing a lipid clinic here, which is much needed. And he has a vested interest in research in lipid management. So it's no surprise that he's inviting his colleague from Harvard, Dr. Erin Michos, to teach us a little bit more about lipid management for cardiovascular prevention. Dinesh, go ahead and introduce her a little bit more formally than what I blundered over.
Well, thank you, Chris, and good morning, everyone. It is really my distinct pleasure to introduce my fellow lipidologist and preventive cardiologist, and above all, a friend, Erin Michos. So Dr. Michos attended medical school in what's my previous hometown, Northwestern University, and then she went on to do internal medicine and cardiology from Johns Hopkins, where she is at the moment, and she's an associate professor in the Division of Cardiology and an associate director of the Preventive Cardiology program there. There's quite a few of us in the audience who have looked at Johns Hopkins as the model institution really for initiating and spreading the word about preventive care across the country, and Dr. Michos has been very instrumental in that. She's internationally known for her work in preventive cardiology and women's health, and she has more than 450 publications and 9 book chapters, and her research focuses on cardio-obstetrics, cardiovascular prevention, coronary calcium, biomarkers. I'm sure she'll cover a lot of that today, as well as lipids and cardiometabolic disease. She's the co-editor-in-chief for the American Journal of Preventive Cardiology. She's an associate editor for Circulation, and she's done several NIH studies, including MESA, ERIC, and she's on 2 mentoring awards at Johns Hopkins University. I've previously heard her talk, and she's a superb educator, and she really knows how to get a message across. So I'm very delighted that she's taken the time to talk to us this morning about lipid management. Erin?
Thank you so much for that kind introduction and for the invitation to speak with you today. I'm going to be talking about lipid management for the prevention of atherosclerotic cardiovascular disease, because we've had some new guidelines in the past couple of years, but more importantly, we sort of have new tools and new goals, and so this will be an overview of all of that. These are my disclosures. Notably, I had been on an advisory board for several pharmaceutical companies that are in the lipid field. So LDL still remains our primary target for atherosclerotic cardiovascular disease prevention. And this is because there's overwhelming evidence from genetic studies, observational studies, and interventional studies that have shown this link that the lower exposure to LDL is proportionally associated with a reduction in coronary heart disease. Now, of course, your genetic studies, your Mendelian randomization studies, the magnitude of lowering is even greater because individuals have been exposed to a lower LDL for longer, essentially their whole lifetime. For observational studies, on average 10 to 12 years, and interventional trials on average of 5 years, but still you see the same thing, that is, if you go lower and lower with LDL, you reduce your risk of coronary heart disease. So it's really important to start thinking about duration of elevation. So it's not only the magnitude of elevation, how high the LDL is, but how long individuals have been exposed to this. So there's been a sort of a thinking of like cholesterol years. I think we're all familiar with smoking pack years. It's been sort of hypothesized that maybe it's around 5,000 milligram per deciliter LDL years is the clinical onset of ASCVD. So individuals who have FH, familial hypercholesterolemia, have had high LDL since birth, and they cross over this threshold earlier in life. And individuals with lifelong low LDL from genetics and healthy lifestyle may never cross this threshold. But I think what's important to remember is even modest or moderate hypercholesterolemia, that exposed over a number of years, that even modest levels of elevated cholesterol can induce earlier onset of ASCVD compared to individuals who've had lifetime low levels. So first, I'm going to talk about primary prevention. And in 2019, I had the pleasure of being a co-author on the ACC AHA primary prevention guidelines. And our guideline did focus on 9 total areas of topics. I'm going to talk today about management of high blood cholesterol. But over all these topics, we had 3 overarching themes: that to deliver prevention is best with a team-based approach, make sure we consider the social determinants of health of our patients, and involve them in shared decision-making for a truly patient-centered approach to prevention. So the key message sort of for primary prevention, and I'm going to get into this in deeper, is that statin therapy is still first-line treatment when we're talking about pharmacotherapy for primary prevention in patients who have elevated LDL above 190. This is enriched with FH patients. This is severe primary hypercholesterolemia. Patients with diabetes who are over the age of 40 are indicated for a statin. And then any adult who's deemed to be at sufficient ASCVD risk after a clinician-patient risk discussion. There's this latter group that takes a little bit of some thought. So our guidelines are risk-based. So why assess risk? Well, of course, everybody needs to work on lifestyle. The most important way to prevent cardiovascular disease is to follow a healthy lifestyle throughout one's lifetime. But when considering drug therapy, estimation of risk facilitates matching the intensity of therapy to the absolute risk of the patient to maximize anticipated benefits and minimize harms of overtreatment. And so we see data from the cholesterol treatment trialists. This was a statin trial meta-analyses, that the number of vascular events avoided depends not only on the degree of LDL reduction, but the absolute risk of the patient. So our guidelines still recommend starting with a 10-year risk assessment using the pooled cohort equations for adults 40 to 75, generally without diabetes or who have LDL 70 to 190, because those who have LDL above 190 or have diabetes are already recommended for a statin. But to estimate this 10-year risk estimation, and we've seen this was first introduced in 2013 and we carried it over in 2019. It includes all the same factors that were traditionally in the Framingham risk score, so has the same input factors, but it was calibrated based on multiple U.S. cohorts that were sex and race specific, and includes total ASCVD, including stroke, in addition to coronary heart disease. And we know that it's reasonably calibrated for a broad U.S. population, but it's certainly not perfect. It can overestimate risk in populations with high socioeconomic status, very engaged patients. So it can tend to overestimate risk and perhaps lead to overtreatment. On the other hand, it can underestimate risk in certain populations, such as those with more social deprivation, HIV, inflammatory disease. These things are not in the pooled cohort equation. So the guidelines recommend this as a starting point. This is the start of the conversation, not the end of the conversation. But generally, low-risk patients, less than 5% 10-year risk, lifestyle is often enough. For individuals at high risk, above 20% 10-year risk, it's lifestyle and drug therapy, high-intensity statin therapy to reduce LDL by 50% or more. And then you've got these broad groups in the middle, the borderline and intermediate risk groups. So first, before I talk about those approach, I just want to mention the lifestyle recommendations that in our guidelines for diet, we gave a class 1 recommendation for the intake of vegetables, fruits, legumes, nuts, whole grains, and fish. We gave a 2A indication to replace saturated fat, which can lead to elevated LDL, with the healthier monounsaturated and polyunsaturated fats. So this wasn't a low-fat recommendation. This is more of a moderate fat recommendation, but using the healthier types of fats. We did say it was still a good idea to try to reduce cholesterol and sodium in the diet and to avoid or minimize processed meats, refined carbs, sweetened beverages, and avoid trans fats. Now, the guidelines acknowledge for this group in the middle, there can be some uncertainty. So they recommend, as part of a clinician-patient risk discussion, to consider risk-enhancing factors, and I'll show them on the next slide. But these are factors that you already know about your patient from their clinical history and from their labs that can help inform more information about their risk. And being interested in women's health, I was very pleased that the guidelines included these female-specific factors of premature menopause and preeclampsia. There's a lot of other ones, including family history and kidney disease, inflammatory conditions that are more common in women like rheumatoid arthritis and lupus. South Asian race ethnicity is a risk enhancer, and then for different biomarkers, persistently elevated hypertriglycerides above 175, non-fasting on at least 3 occasions, having a high CRP, an elevated lipoprotein A, and an elevated ApoB were all risk enhancers. And when present, this would favor the initiation of statins for those that were otherwise borderline or intermediate risk. It kind of moved them into a higher risk category. But the guidelines acknowledge that even after you estimate 10-year risk, and even after you consider those risk-enhancing factors, there can still sometimes be uncertainty about the net benefit of statin therapy or patient indecision. And in these situations, when there's uncertainty, the guidelines say with a 2A indication, you could consider a coronary artery calcium score to help refine the risk a little better and guide shared decision-making. So you may be familiar with this test. It's done by non-contrast CT. It's a low radiation protocol, about 1 millisieverts, same as a bilateral mammogram. And as atherosclerosis is building up in the arteries over decades, a certain percentage of it can become calcified, and calcium, of course, shows up right on x-rays without any dye. So it's really a marker of atherosclerosis itself. You're kind of measuring the disease itself. It turns out that it's really the superior marker of risk. It predicts better than risk factors. It predicts better than age. It predicts better than LDL, because it's really just measuring atherosclerosis or capturing an aspect of atherosclerosis itself. And so it's integrating a lifetime exposure of genetics, traditional and novel risk factors, and its presence or absence can upgrade or downgrade risk. And this is based on large epidemiology studies that show it's predictive of risk. This is data from the MESA study. This red line is the 7.5% 10-year threshold, which we generally consider as the net benefit threshold for statin. So I've lost a line, it seems, on the screen, but there was a very light gray line that was down here going like this. And this was a 0 scores. So a zero calcium score isn't 0 risk. There are some events that occur in people with a 0 score, but it's a low enough risk that patients and their clinicians may feel comfortable deferring statin therapy because it's sufficiently sort of below the 7.5% threshold. On the other hand, any non-zero score crosses over this threshold over 10 years in a graded fashion. With the higher the score, the higher the risk. Recently, the National Lipid Association also released a statement about the use of coronary calcium, and they also endorsed it, particularly for the high scores above 100, but they took it a step forward and said, really, if you have very high scores above 300 or particularly 1,000, to treat them sort of like secondary prevention, to use a high-intensity statin to try to achieve that 50% lowering of LDL and optimally an LDL less than 70. And so this may require add-on therapies to get to these goals. So that's more of a secondary prevention approach. And they also said that if the coronary calcium score is above 100 and a patient doesn't have increased risk of bleeding, that it may be reasonable to treat with aspirin therapy, 81 milligrams for primary prevention. And this is based on some modeling from the MESA study about this threshold of patients being high enough risk where they may favor a net benefit threshold for aspirin in primary prevention. Which patients might benefit from knowing their calcium score? Again, not everybody needs a calcium score if you already have enough information to make recommendations about their treatment plan. Patients who might be reluctant to initiate statins, I have a lot of this that I get referrals for. Patients that wish to understand a little bit more about their risk. Patients who've had symptoms that they're concerning for statin-associated muscle symptoms, trying to figure out how much do we keep pushing, keep trying different statins, different doses, different regimens, or using non-statins. If someone had a 0 score, that would reclassify them to a lower risk group. Now, older patients get so many points in this pooled cohort equation based on age that most older adults are above these, 7.5% threshold just based on age. But aging is very heterogeneous, and not all older adults, are at increased vascular risk. And so certainly a 0 score in an older individual is very reassuring. And then a middle-aged individual who may be borderline, increased risk or have risk enhancers, the presence of coronary calcium showing already that they have atherosclerosis present may certainly favor initiation of statins in this group. The guidelines also have recommendations about patients with diabetes. So you don't need the 10-year risk score to make the decision to start. It's recommended that all adults 40 to 75 with diabetes and primary prevention are recommended at least a moderate intensity statin. But if you did calculate their 10-year risk and it was high, or they had multiple other ASCVD risk factors, it's reasonable then to use a high intensity statin to reduce LDL by 50% or more. And in addition to the traditional cardiovascular risk factors, there's also diabetes-specific risk factors that would favor high-intensity statin, including individuals who've had diabetes longer, more than 10 years for type 2 or 20 years for type 1, if they have albuminuria or low GFR, or retinopathy or neuropathy, or a low ankle brachial index. Now, what about individuals with an LDL above 190? Again, you don't need to calculate 10-year risk for this. You just need to start a statin for them. Anybody that's an adult over the age of 20 with this, high LDL, to use a maximally tolerated statin. Again, I showed you that they have very high lifetime risk. If someone has an LDL above 190 and on a maximally tolerated statin, then they're unable to achieve a 50% lowering of LDL or remain above 100 milligrams per deciliter, it's recommended to add ezetimibe. And you can also consider a PCSK9 inhibitor in these individuals if they have heterozygous FH whose LDL remains above 100 despite statin and ezetimibe. And I just a plug, not to miss FH. It's really undertreated, and it's very common because it's autosomal dominant. 1 in 250 people have definite or probable FH. Because it's autosomal dominant, it affects men and women equally in terms of prevalence. And essentially, the presence of FH sort of removes all of the female advantage for ASCVD. So men and women with FH develop clinical ASCVD around the same ages. So a 20-fold increased risk in CVD with an earlier onset, 10 to 20 years earlier onset of ASCVD in men and 20, 30 years earlier onset in women compared to their non-FH matched peers. And it continues to be undertreated. But if you look among your population of your young adults who have MI, 1 in 10 young adults who had an MI would have FH. But, most 60% of them, if they were young and had an MI and have a family history and an LDL above 160, they're likely to have, most likely to have FH. So what about older adults for primary prevention? And I will mention that, there's less data on this in terms of trials. There is a trial ongoing, the preventable trial looking at aspirin in older adults. But the guidelines give you a lot of choices because aging is very heterogeneous, and some older adults are thriving at this age and have another decade or more of life. And so if someone's older and doing really well and they have a good life expectancy, it's reasonable to use a 2B with a 2B indication, a moderate intensity statin. On the other hand, if you have an older adult who has had functional decline, multimorbidity, frailty, nursing home bound, have malignancy or other reduced life expectancy, it's reasonable to stop the statin. And then it's also reasonable to consider coronary calcium score for those 76 to 80 if you're unsure. Most adults in this range will have a positive coronary calcium score, but if it happened to be 0, it certainly would be incredibly reassuring in this age range. Now, what about young adults? So the pooled cohort occasion starts at age 40, but again, you need to screen risk factors in young adults. You don't want to miss FH. And for adults 20 to 39, or those 40 to 59 who are at low risk, and to consider calculating a lifetime risk score. There's no absolute lifetime risk score where we have a recommendation for statin per se, but knowing high lifetime risk can help facilitate lifestyle changes and make sure we track risk factors more closely. And just to make sure we're on all the same page with the terminology, when I'm talking about high intensity statins, our goal, those should lower LDL by 50% or more. And really that's just your Torva 40 to 80 or your Residual 20 to 40. Moderate intensity statins are all of these in this range and lower LDL in the range of 30 to 49%. Now the guidelines, none of the guidelines specifically recommend low intensity for any group. That being said, for some patients, low intensity statin is their maximally tolerated statin, but make sure that it's at least tried that we get patients on the guideline recommended intensity. There's a lot of undertreatment. Then moving to secondary prevention, this is also risk-based because there's a difference between a patient who maybe got a stent 10 years ago for stable angina versus a patient who's in your CCU with a recent acute coronary syndrome. And so the guidelines stratify them differently. So for secondary prevention, not at very high risk, it's recommended to use a high-intensity statin class 1 indication to lower LDL by 50% or more. But if on that maximally tolerated statin, the LDL remains above a threshold of 70, it's reasonable to add ezetimibe with a 2B indication. And then for those that are very high risk, and I'll show you on the next slide who we mean by this, but again, a high-intensity statin or the maximally tolerated, if they remain above an LDL threshold of 70 on this statin, it's reasonable to add ezetimibe. This was a 2A indication, a slightly stronger indication. And then if a patient is on a maximally tolerated statin and ezetimibe and their LDL remains above a threshold of 70, it's recommended with a 2A indication to add a PCSK9 inhibitor. And who are the very high-risk patients, whether they're patients who've had a recent coronary syndrome, ischemic stroke, MI, PAD, with at least one high-risk condition, such as older age, diabetes, hypertension, CKD, smoking. These risk factors are so common in these individuals. And I will mention, I guess I don't have the slide on this, the European guidelines are even more aggressive with their targets. The European guidelines recommend a lowering of 50% or more of LDL for this group, but also achieving a target LDL less than 55 milligrams per deciliter. So unfortunately, even on statin treatment, there can be residual risk, meaning that, even though statins reduce risk, events still occur both in primary prevention and secondary prevention, and high-risk secondary prevention, it may be as much as 20% of patients in 5 years will have a recurrent event. Now, some of this residual risk is due to non-lipid factors such as hypertension, diabetes, smoking. It's important to optimize all risk factors. But some of this is due to residual burden of atherogenic dyslipidemia. And we do have now several therapies that have been shown that adding additional therapy, additional LDL lowering to statins can further reduce cardiovascular risk. First we had the Improve It trial with patients with acute coronary syndrome, adding ezetimibe, reduced risk, by 4%. But, because these are such high-risk patients, you only needed to treat 50 individuals to prevent one additional vascular event. And then we had the PCSK9 inhibitors with about a 15% reduction over a short period of 2 to 3 years, similar for evolocumab and alirocumab. So, but there is, of course, difference within secondary prevention in terms of the benefit, again, which is why the U.S. guidelines really focused on the very high-risk patients. That if you look at the FOURIER trial, which studied evolocumab, a PCSK9 inhibitor in patients with stable ASCVD, there were high-risk groups, such as those that had a recent MI within the past 2 years, who've had more than 2 MIs, or multi-vessel disease. These individuals at very high risk gained even greater relative risk reduction and absolute risk reduction compared to their more stable counterparts. And so really focusing on these groups. And particularly, I want to emphasize the importance of patients with peripheral arterial disease, that in FOURIER, PAD patients, regardless of what arm they were randomized in, had much higher event rates compared to the non-PAD patients. But again, evolocumab, a PCSK9 in this group, had a greater relative risk reduction and absolute risk reduction compared to the overall trial. And I'll mention this is for cardiovascular outcomes, but additionally, evolocumab in this group reduced MALE events, major adverse limb events, so it can help their limbs and their hearts. Oh yes, here's my European guidelines slide. So as I mentioned, the European guidelines even are more intensive for both primary and secondary prevention. They have high-risk groups recommending both an LDL reduction of 50% and an additional goal of reaching less than 55. And I meant in my practice, because I do think lower is better for these very high-risk individuals, I try to get to these targets. In FOURIER, the average LDL was around 30. So, these guidelines, previously we did a meta-analysis looking at does baseline LDL matter in terms of the benefit of additional lowering. We did a meta-analysis of 53 trials, including the therapies at this time, statins, ezetimibe, PCSK9. And for cardiovascular mortality, we really saw the benefit if the LDL remained above 100. But for reduction in major adverse cardiovascular events, it was irrespective of the baseline LDL. The lower the LDL, we still saw further reduction in MACE events. And it was similar for both men and women. There was no interaction by sex. For the benefit, this is the per 1 millimole per liter or 39 milligrams per deciliter reduction in LDL. You get about 15 to 19% reduction in a major adverse cardiovascular event. And women tend to be undertreated, and yet they benefit just as much if they're at similar risk. And so make sure that we treat patients appropriately, irrespective of sex, and there's no sex-specific recommendations. These apply to both. But as I mentioned, now we're in a new era. We got all kinds of new kids on the block, so it's a really exciting time to be in the lipid field. Talk a little bit about inclisiran, bempedoic acid. There's an antisense oligonucleotide that's targeting lipoprotein A. We have evolocumab and other therapies, evanoscumab that's targeting PTL3. We also have an ASO for an ApoC3, triglyceride lowering. So we have new therapies on the horizon. So first, bempedoic acid is already here. You may be using it. It was FDA approved in February 2020. It's an oral agent approved for LDL lowering. It works in the cholesterol synthesis pathway, the same pathway that statins work in, but it works upstream of statins. So bempedoic acid inhibits ATP citrate lyase, so it blocks in this stage where statins inhibit HMG-CoAce reductase. But both work in this pathway, and ultimately what it leads to is less cholesterol synthesis. And that leads to upregulation of the LDL receptor on the surface of the liver. And so with more receptors, you clear more LDL out of circulation. Now, why this is maybe attractive for some patients is that it's a prodrug, and the enzyme to activate it is only found in the liver. It's not found in muscles. So it doesn't have the same muscle-associated side effects that statins do. It can lower LDL kind of by itself in the range of 18%. It is greater in combination with ezetimibe, but it's similar kind of as monotherapy in the ezetimibe range. One thing you have to keep mindful of is that there can be an increase in uric acid levels, so that needs to be watched. But one potentially attractive thing is that the trials consistently show that it lowers CRP. So it'll be interesting to see. There's an outcome trial ongoing right now that this is approved based on the LDL lowering in patients who have ASCVD or FH that can't get to goal. And it's particularly helpful in patients that are statin intolerant. But we still have an outcome trial ongoing, which I was pleased they enrolled 50% women, looking to see whether bempedoic acid can reduce major adverse cardiovascular events in patients that are statin intolerant. And we'll see whether the benefit is related to the LDL lowering or whether potentially also because it can lower CRP. Now, another new agent, which I hope will be FDA approved in 2022, is another type of PCSK9 inhibitor, inclisiran. So evolocumab and alirocumab are monoclonal antibodies, but inclisiran is a small interfering RNA that targets PCSK9. So it's preventing the synthesis of this protein. And the Orion 10 and Orion 11 trials had shown about a 50% reduction in LDL with inclisiran and getting patients down to goal around 50 milligrams per deciliter. So it's been approved in Europe. It's not yet FDA approved in the United States. It's undergoing regulatory review, so we'll see. We are awaiting an outcome trial for this too, Orion 4 outcome trial. But again, I feel pretty comfortable that with these agents that, we know that if we can lower LDL, particularly through mechanisms upregulating the LDL receptor, it's likely going to translate to meaningful events. Now, lipoprotein A, as I mentioned, is a risk-enhancing factor. Some patients with very high levels have risks similar to FH patients. it's a riskier form of LDL cholesterol that's associated with early onset of ASCVD and also valvular calcification, and it's highly heritable. And up to this point, we didn't really have a lot of therapies that could treat it. Statins don't, unfortunately, lower lipoprotein A. The PCSK9 monoclonal antibodies, evolocumab and alirocumab, can lower it about 26%, so that's helpful in patients with FH. But there's a new drug, an antisense oligonucleotide, an ASO drug, that blocks the synthesis of this, and at least in these phase 2 trials have shown, an 80% reduction in lipoprotein A, so that's exciting. But we want to see, does this translate to events reductions? And so there is an outcome trial ongoing, the Horizon trial, so we'll see if this can actually reduce events. And some modeling suggests that you have to lower lipoprotein A a lot to have the same degree of reduction in events that you can get with LDL lowering. Now, evolocumab is the one I mentioned earlier before that is a monoclonal antibody that targets ANGPTL3. So ANGPTL3 inhibits lipoprotein lipase, and so this leads to increased LDL, HDL, and triglycerides. So if you inhibit ANGPTL3, either with a monoclonal antibody like evolocumab, or they're working on ASO drugs for this, you can reduce LDL, HDL, and triglyceride. But the reason why this is interesting or potentially useful is that this is a drug that works independently of the LDL receptor. So it's blocking lipoprotein lipase, so it doesn't involve the LDL receptor. So that makes it useful in patients with homozygous FH who don't have, LDL receptors. And so it was FDA approved for FH patients, homozygous FH patients, or patients in this trial with refractory hypercholesterolemia, despite statins, ezetimibe, and PCSK9. This trial was on a background of PCSK9 inhibitor and showed evolocumab can lower LDL substantially, about 50%. So it's currently, quite costly and requires a lot of approvals, but for your patients that have homozygous FH, it's a new option. And just for a background review of the guidelines, I had the pleasure of writing this review article for the New England Journal of Medicine a couple of years ago when our guidelines came out. So just another reference source, maybe for your residents or your medical students. All right, so we got these guidelines. So what's happening now in the real world since these guidelines came out? Well, the Santorini registry was in Europe, and this was presented earlier this year, and it looked at data from patients that were at high or very high risk, cardiovascular risk, who required lipid-lowering therapy from 14 U.S. countries, recruited 2020 to 2021. So this was after the guidelines. Unfortunately, my boxes seem to have shifted on these slides, but basically overall for these high-risk patients, the LDL was 95 is what it says here. So it was very much not at target. And 19% of patients were not on any lipid-lowering therapy. These very high-risk patients, not on any lipid-lowering therapy, and combination therapy was very underutilized. And I'm sorry, my boxes shifted, but 17%, only 17% of these high-risk patients were on a combination of statin plus ezetimibe, which are both oral agents. And only 5% of these patients at very high risk were even on a PCSK9 inhibitor. In 2020, we've had these were out now already, so they're not being utilized in practice. Well, that's Europe. What about the U.S.? Well, the Gould registry looked at patients with ASCVD requiring lipid-lowering therapy. So again, these are high-risk patients, and this is data that has just came out, after our guidelines. 36% of these high-risk patients with ASCVD still had an LDL above 100, and 50%, had LDL 70 to 99. So we have, 2/3 of these ASCVD patients are still above this threshold of 70, where our guidelines would recommend intensifying. But unfortunately, only 17% of patients had intensification over the 2 years in this registry. So there's a lot of clinical inertia, and I'm moving towards recommending using a lot of combination therapy up front in these very high-risk patients. So we know, additionally, not only prescribing it, but adhering to therapy is a challenge in practice. And unfortunately, suboptimal adherence is associated with increased mortality. This is data from a VA system, but as the adherence to, based on pharmacy data, medication possession ratio, as adherence goes down to their statin therapy, there's increased risk of mortality. And, this is data, I think, from the Kaiser, but really just showed that, the attrition and use of people that were, prescribed statins, 12% didn't fill them, and another 12% didn't start them, and 29% didn't finish the course at a year. So at a year, you only had like less than half that were still adherent to the prescription. So one challenge is many patients report statin-associated muscle symptoms, and I'm going to talk about the nocebo effect next. I do think there are some factors of patients that might be more likely to experience this, such as older age, women who have other comorbidities, Asian descent. But, the statin therapy is overwhelmingly safe. We have hundreds of thousands of patients and numerous clinical trials. Myositis is very, very rare, serious muscle injury. Is 1 in 10,000. Liver dysfunction is very rare too, 1 in 100,000. The FDA says we don't even have to measure LFTs anymore, although I still do. Now, there is a small increased risk of new onset diabetes. This is pretty, this is patients that were sort of already on the pathway there. These were patients that were pre-diabetic who had elevated BMI, elevated A1C above 6, and the small bump in blood glucose, 5 milligrams per deciliter, kind of crossed them from pre-diabetes to diabetes. But it doesn't take someone who's euglycemic and make them diabetic. And patients are really worried about this, but there's overwhelming evidence of the benefit of statins among patients with diabetes. So really, I use this as a time to really double down on lifestyle. You work on weight loss and things to help mitigate this small bump in blood glucose. And really, data has not confirmed or really found any relationship between cognitive decline. If anything, statins have been shown to reduce the risk of vascular dementia, and there's really been no association with cataracts or cancer. So, one real challenge is that the nocebo effect. So in trials, when patients are blinded, and granted, trials do have a run-in phase, so it's different than real-world practice. But in trials, there is no difference in withdrawals from placebo and statin due to muscle symptoms when people are blinded. But in real-world practice, we know as much as 20 to 30% of patients report statin-associated muscle symptoms. So one of my favorite trials that were presented and recently published in the past year, the Samson trial, was an N of 1, meaning that patients served as their own control. And they recorded, these were all statin patients, the 60 patients that had statin-associated muscle symptoms, that were statin intolerant. And the patients were given 12 bottles. And 4 bottles, they had a statin in it. 4 bottles, 4 months, they had a identically matched placebo. And 4 bottles were empty. So the bottles were empty, so patients knew they were taking nothing during that month. And then they were asked to record their symptoms. And what did we find? Well, patients did report muscle symptoms on statin therapy, but 90% of the symptoms were also elicited on placebo too, compared to when they knew they were taking nothing, the bottles were empty. So patients really do get side effects from statin therapy, but 90% of their burden was elicited by the placebo tablets. It was really the act of taking the pill rather than what was in it. And then when the authors presented this back to the patients and shared this with them, they were actually able to get 50% of the patients back on their statins. So I would really encourage that we, for our patients, there's so much overwhelming evidence of statin benefit, to really do a re-challenge. Most patients that reported statin intolerance are able to, tolerate a statin on a re-challenge using different agents, different doses, or sometimes I use alternate day dosing. And then I want to end a little bit with the sort of the challenge with omega-3 supplements, some little bit of perhaps controversy or confusion. So we do know that triglycerides are a marker of residual risk for sure. So this is data from the Prove It trial, patients with acute coronary syndrome, that patients were on statins and got their LDL less than 70, but those who remain with a triglyceride above 150 were at 41% increased cardiovascular risk compared to statin-treated patients who also had their triglycerides at goal. So, first to review reversible causes for high triglycerides. So there's a lot that can be done with lifestyle, patients that have high fructose or sucrose intake, simple carbs, alcohol, low fiber, sedentary, poor glycemic control, or hypothyroid and nephrotic syndrome. So working on those. And also review patients' medication lists. There are a number of drugs that can elevate triglycerides, including estrogens, tamoxifen, immunosuppressive drugs, protease inhibitors, thiazide diuretics, acid sequestrants, which we don't really use that much anymore, but those are contraindicated in patients who have high triglycerides above 500. But it's thought that omega-3s may have some benefit beyond triglyceride lowering, including anti-inflammatory and anti-thrombotic effects. There's a slight bleeding risk with omega-3 fatty acids. That's thought that maybe it's through to this anti-thrombotic effect that might lead to cardiovascular protection. But unfortunately, numerous studies have not shown any benefit with the dietary supplements, usually 1 gram DHA, EPA, they can get over the counter. And I don't encourage patients to take dietary supplements of omega-3s. They're not FDA regulated, being a dietary supplement, and they can contain a lot of contaminants. Often just because this is a fat, it can be oxidized pretty easily. And this one study suggested, over a third contained saturated fats as well, so not just the polyunsaturated fats. And it's really difficult to get to the kind of blood levels of EPA that I'm going to show you that's been associated with cardiovascular protection. So I don't recommend them, and this is just one example that this is a dietary supplement. It's solid at room temperature like you would be for saturated fats like butter or coconut oil, or prescription omega-3, is liquid at room temperature as you would expect for a polyunsaturated fat. So really the landmark trial was the REDUCE-IT trial. This studied specifically icosapent ethyl, which was a highly purified form of EPA at 4 grams a day. And there was a major reduction, 25% reduction in major adverse cardiovascular events with a very favorable number needed to treat. So REDUCE-IT was enrolled patients with ASCVD or diabetes with another risk factor who were statin treated. So this was all on a background of statins, who had elevated triglycerides above 135. Now, interestingly, at least the benefit of icosapent ethyl in this trial didn't seem to differ by baseline triglyceride levels, although enrolled people above 135, but it didn't seem to matter what their entry triglyceride levels were. And notably, the benefit seemed to be independent of the triglyceride lowering effect, and that regardless of whether they remained above 150 or achieved less than 150, the benefit of icosapent ethyl was similar compared to placebo, regardless of achieved triglyceride levels. So it seems like the mechanism was far more than just the triglyceride. And there's been data from a CT arm looking at icosapent ethyl that did show there was a reduction in low attenuation and fibrofatty plaque, as well as non-calcified plaque, compared to the placebo that had some progression. And since then, many guidelines have endorsed adding icosapent ethyl, similar to the REDUCE-IT population, patients with ASCVD and triglycerides above 135. Now, the confusion, I guess, came then when we had another trial, Strength, that was also, prescription grade high dose 4 grams, but it was a combination EPA and DHA, carboxylic acids. It was also similar to REDUCE-IT, that it includes patients that were at high cardiovascular risk, both primary and secondary prevention patients. Again, 4 grams a day of this carboxylic acid combination of EPA and DHA. And it was stopped early due to futility. Essentially, you can see it's as flat as it can be. There was really absolutely no signal for benefit with this omega-3 combination. And then there was the AMEMI trial that was looking at also a combination EPA-DHA at a lower dose, 1.8 grams a day, in older patients who had a recent MI, and also showed no benefit. And then there was this increased risk of AFib, which we also saw the risk of AFib in Strength and REDUCE-IT, but it was more notable in this trial of older adults. So how do we put all this together? Well, I do think blood levels of EPA do matter. In the REDUCE-IT trial, we did see there was a sort of a dose response. So while we didn't see the benefit was dependent on triglyceride levels, the benefit did seem to correlate with achieved EPA levels. So once you got above 100 for the blood levels of EPA, that there was significantly lower risk of major cardiovascular events. And REDUCE-IT was not just an N of one, the only trial that looked at this. There was another trial, the JELIS trial, that looked at icosapent ethyl pure EPA, and it was an open label trial from Japan. That's probably why it didn't get a lot of attention, because it was published in 2007. And this had no comparator arm. There's been a lot been made of the mineral oil comparator REDUCE-IT, but this was comparing stat plus EPA versus statin alone, and there was no, mineral oil or comparator. And it was similar, with this pure EPA only, 1.8 grams a day, 19% reduction in major adverse cardiovascular events, and even a greater reduction if you pull out the group that had high triglycerides, similar to REDUCE-IT criteria. So you have two trials that kind of showed the same thing for outcomes. So if you look at blood levels again, so in JELIS, which was in Japan, they started with a much higher level of EPA, and so with 1.8 grams, they got up to 170, which is kind of in the range that we see with REDUCE-IT. So REDUCE-IT, because it included a lot of Western countries like the U.S., where fish intake is low, individuals start out with really low levels of EPA, but with 4 grams of EPA got to the high levels, the same levels with JELIS. Now the strength trial, which was the null trial, again started with very low levels, but the achieved levels were not even as high as the baseline levels in JELIS. So the achieved levels were much lower and did not get into the range that EPA did. So, that REDUCE-IT did with this higher dose of EPA. So one could be that they just didn't get high enough EPA levels. And it may be something about DHA, not that it's toxic, but the way it integrates in cellular membranes may be offsetting some of the benefits with EPA. But in this meta-analysis that I was a part of, we did see that these outcomes really we saw with the combination with EPA alone, and we really didn't see the same reduction with the combined EPA DHA. So I think the type of fish oil matters. And I'll just mention, because there's been a lot of talk about the mineral oil comparator in REDUCE-IT, and it'd be nice if they did it again with a different type of comparator. They say they picked the mineral oil because it was a match to kind of look like an oil, to look similar to the icosapent ethyl, which is an oil. But when they got this approved by the FDA, they did do analyses, because the mineral oil, there was a slight increase in LDL and a slight increase in CRP that really couldn't explain away the 25% reduction. But even if you looked at those who, in the placebo arm here in the red, who did and did not have an LDL increase, or who did or did not have a CRP increase, you still see the benefit of icosapent ethyl regardless. And so this was, the FDA did review this and felt that it wasn't driven by the comparator. And another CTA study, if you look at the mineral oil comparator from Evaporate versus a different control, it was a garlic study, and their placebo in that trial was a cellulose placebo, so a completely different placebo. So if you match plaque progression comparing these two placebos, you don't see that mineral oil is suddenly causing more accelerated plaque. It was very similar to this other type of placebo. So I really don't think it's all the placebo arm. So I think that polyunsaturated fatty acids are not the same, that the type matters. It does seem to be specific to EPA. I think the dose matters, and a background of low fish intake, I think you're going to need really high doses to achieve those high levels of blood levels of EPA, but certainly we need more confirmatory trials. So in summary, LDL cholesterol is causally related to ASCVD risk. Lower accumulation of exposure to LDL delays the onset of CVD and slows plaque progression. So you want to be lower for longer with your LDL. High-risk patients, such as those with clinical ASCVD, these high-risk, very high-risk patients, who have residual burden of atherogenic lipid particles benefit from more intensive lipid lowering therapy. So let's not reside on inertia and really get patients to goal. Patients maintaining intensive LDL reduction for longer have greater risk reduction. And of course, lifestyle is the foundation. Statins are still first line. We got ezetimibe and PCSK9 to be added for very high risk. We now have bempedoic acid. We don't have an outcome trial yet, but it may be particularly helpful for statin-totolerated patients, but really anybody to help get to LDL to goal, and those newer agents in the pipeline like inclisiran and icosapent ethyl for patients who have elevated triglycerides have also been shown benefit. And just a final plug, as you heard, that I was the co-editor-in-chief for the American Journal of Preventive Cardiology. This is the official journal for the American Society for Preventive Cardiology. So I encourage you to read our journal, submit to our journal, anybody interested in preventive cardiology, and to join our society. So residents and fellows, membership is free to join when you're in training. And thank you, and I'll stop sharing so I can take questions. Let's see. I can get back to stop sharing. All right, I think I'm back.
Thank you, Dr. Michos, and Dr. Cowher, looks like you had a question.
Well, yeah, I have a couple comments and questions. And first of all, I want to congratulate Erin on doing this so fantastically. I mean, I've heard several of your talks, and it's amazing the breadth of information you can cover in such a simple manner, and that was a terrific overview of the entire lipid space. The one thing I want to point out and echo to our audience is, as Dr. Michos mentioned, despite all these guidelines, a lot of our patients are being undertreated, and that's why you have to, not just stop at the initial dose of statin therapy, but increase the statin. The European guidelines are far more aggressive, saying get your LDL down to 55. For high-risk patients, such as those of South Asian ethnicity, we are advocating getting the LDL down to under 30. And so my question to Dr. Michos is, are you doing that for your extreme risk patients in your practice? Are you targeting to 30? Do you care? One of my colleagues asked me the other day, somebody's LDL was 18, and they were a little afraid of neurocognitive side effects, so I reassured them that's not a problem. I've had people with LDL of 1s in my practice. So number one, how aggressive are you? And then what tools do you use beyond their clinical history to guide you for LDL targets of less than 30? And number two is Lp(a). That's really an amazing story that's evolving. We have enrolled patients in Horizon with pelacarsen. Do you think that accounts for some of the residual risk? And do you routinely check it? We are. And just wanted to get your thoughts on Lp(a) also.
Yeah, these are great questions. Let's start with the first one. So there really is not any shown safety concern with getting LDL to too low based on interventional and genetic studies. So the concern came from observational studies that individuals who had very low LDL seemed to be at increased risk for hemorrhagic stroke and for bleeding and cognitive problems in observational studies. Now keep in mind, in observational studies, associations are not causations. So many patients with low LDL are frail and had cancer and comorbidities or drink too much alcohol. And so there may be health concerns about why their LDL was low. But if you take your best cue from nature, genetics, there is individuals who have, knockout mutations in their PCSK9 who have lifelong LDL from birth, and they don't develop neurocognitive outcomes, adverse neurocognitive outcomes. They don't develop hemorrhagic stroke. That's not been seen in genetic studies. And in interventional trials, in 4-year, the average LDL on treatment was 30. That means half of them got to LDL under 30. There was no dose dependent risk in hemorrhagic stroke. There was nothing that there was no increased risk with lower LDL. They had a separate Ebbinghaus, cognitive study, and they showed no cognitive changes on these therapies. So really, I don't see any concern with going too low, especially, keep in mind that if you look at neonates and animal populations, or your infants, their LDL is 30. So, we're used to these really high levels, but you really don't need very much cholesterol, and your cells, your body, makes its own cholesterol. So I'd be reassuring. So I treat, I kind of follow the European guidelines. I try to get to patients under 55. It seems to be from data that atherosclerosis stops progressing once you get the LDL less than 55. But if I start a PCSK9 and it drops, certainly under 30, I say great, and I keep them on current therapy. I don't get worried and pull back. And some of these times when you get values of 0 or 1, it may be that your lab is estimating LDL through the Friedewald equation. And the Friedewald equation was not ever calibrated for these very, very low LDL levels. And so that may be not as low as you think. It may be a problem with the estimation. And we have other equations, or you can directly measure LDL. And then getting to lipoprotein A, if there's patients that are on a high intensity statin and they have high LDL and they don't seem to be getting to goal, and they swear, I'm taking my statin, and you don't see that 50% reduction, it could be that they have high lipoprotein A, because when you measure LDL, you can't capture how much is lipoprotein A unless you measure lipoprotein A specifically. So that may be one cause of what we call statin sort of resistance, maybe lipoprotein A. But yes, I measure it in everybody. Our guidelines in the US say measure it in people with family history or patients who have early onset ASCVD. It's a risk enhancer. The European guidelines say measure in everybody at least once because it's highly heritable. It doesn't change so much, very little with diet and lifestyle. So you can, essentially measure it once. And again, it's a risk enhancer. So I do treat a lot more aggressively if I know they have lipoprotein A. Although statins don't lower lipoprotein A, statins lower LDL, and we know statins reduce major vascular events. So if they have an elevated lipoprotein A, I still use statins first because I'm overall lowering their vascular risk.
Can I please
Fantastic. Thank you.
Dr. Carter, can I ask a question, please?
Absolutely.
This is Garby Sohi. I'm one of the faculty members. The success of lifestyle changes, in my view, is very poor. It depends on the type of patient, social order, inequity in healthcare that we give. Most of us just give up because we don't reach the goal. I know we've been talking about this for a very, very long time, 30, 40 years in my experience, but the lifestyle changes have not succeeded at all in my view. It succeeds in some group of people, but mostly the patient that I see in the clinic is not working. There was some presentations in the last week of inequity of healthcare that we provide. I think that has something to do with it. The next question I have about ecozap and ethyl, how much are you using it? Do you have that in your practice? How many patients do you have it on?
I'm sorry, I missed the last one. How many patients do I have on what therapy?
Ecozap and ethyl.
Icosapent ethyl. I actually use it a lot since Reduce It came out. So yeah, the lifestyle is a challenge, but I think any effort is worth the effort. And using a team-based approach to care, and I have them, our nurse educator does follow up with them. Certainly, anybody who's had an ASCVD event who qualifies for cardiac rehab, make sure we use cardiac rehab. And empowering patients through different apps and mobile health tools and things like that. But yes, lifestyle can be really difficult to challenge to implement. And of course, for very high risk patients, you want to do lifestyle and pharmacotherapy. So you're doing both at the same time. And then icosapent ethyl, yes, I use it for patients that are like the Reduce It population. So patients who have ASCVD or diabetes with another risk factor. I get their LDL at goal first, so I make sure they're well treated with their LDL and make sure they're on a statin. But if they remain above triglycerides above 150, I will use that one. I don't use the dietary supplements of omega-3s that have not been shown to work. And if you follow the indications for the FDA approval, sometimes you have to fill out some pre-auth forms. But generally, I've been able to get it approved if they meet the FDA approval indication.
All right, and Dr. Michos, so Dr. Kruger has a question, and there's 3 questions in the chat area. I know we're getting a little thin on time, but want to try to get everybody in. But go ahead, Dr. Kruger. I'll let you ask. Go ahead.
So I'll ask quickly, you mentioned the value of coronary calcium scanning. Do you have a recommended LDL level that you would say, I think you need to have coronary calcium scanning, even if it's like 90 or 80 or?
Yeah, well, I mean, I use coronary calcium scoring, to help refine risk a little bit better. So if somebody has these risk enhancing factors, like a woman, if she's had a history of preeclampsia, I don't usually score if they're under age 40, but so these are adults over the age of 40. But if they had a history of preeclampsia, if they're South Asian, if they have, any of those risk enhancing factors, sometimes, their LDL is like 90 and it doesn't seem that high, but they have a strong family history. So do you put someone on a statin whose LDL is 90 if they have a strong family history? Well, I get a coronary calcium score. And if they already have atherosclerosis, then I do. So I do if they have another major risk factor if their LDL doesn't clearly qualify for statin on its own, but they have other risk factors, then I will get them because I think it's useful. And for younger adults, the warranty period of a 0 score is a little bit less. I mean, a 0 score, it means they're low risk in the short term, but they may still have high lifetime risk. So if the score is 0, I may rescan in 5 years to see if they're still 0 if I haven't started a statin. If the score is already elevated, I just treat and we don't follow the calcium score on therapy because the statin shrinks plaque, it shrinks LDL. The statin doesn't remove calcium. So the calcium is not going to ever go away. The patients get frustrated that their calcium scores don't go down, but that's not how so it's more to decide who you should initiate. And if it's 0, it's worth repeating to see if it's still 0. But if it's already elevated, it's not a useful test to follow on statins because statins are just going to shrink LDL, make plaques more dense. And actually the calcium score will go up on statins, but actually it's converting the plaque into a more dense, stable phenotype.
Thank you.
All right, there's 3 questions in the chat area. The first one is from Dr. Robert Emmons, actually in our oncology division, and he wanted to know, can you comment on whether you ever consider looking for, TET-2 mutations in the blood cells of your patients as per the data that emerged in 2017?
No, I can't say that I've been doing that in my practice. I don't know if Dr. Calvero wants to comment, but I haven't been doing that.
Now we don't do it routinely clinically. It's part of the genome-wide association scores that people are looking at, and so you have obviously coronary disease being a polygenic disorder, and then there are monogenic disorders that lead to spikes in risk for certain individuals. So it falls in that category. So if you had someone with a family history or somewhere where you were suspicious of doing this, you would do it. But I'm telling you, the genome-wide association scores for coronary disease are becoming hot. And I think we'll, in the next 10 years or so, see practice changing to incorporate them more. What do you think, Erin?
Yeah, I mean, I think the polygenic scores might be helpful in young adults because I mentioned coronary calcium is not that helpful in 20 or 30-year-olds most of the time because it's the plaque hasn't had time to calcify yet. But at least those with elevated genetic risk scores, it may be somebody that you may want to pay more attention to with the polygenic risk and certainly double down on lifestyle, but maybe have an earlier thought about initiating statins earlier in those groups.
Exactly.
I just wanted to clarify that this is not a genetic risk they're born with. This is an acquired clonal risk in a small pool of hematopoietic cells that then changes the biology of monocyte macrophages and accelerates atheroscleroma. So I was wondering whether or not that's something, given the emerging data, that we might screen for in the background to see what the true incidence and problematic issue is in the population. These are patients that have no blood cell count abnormality, but have a clonal hematopoietic defect that seems to give rise to these issues.
Yeah, I mean, there's been a lot of work looking at these clonal defects and things, but I haven't personally used it in my own clinical practice yet. But I know it's been an emerging area with a lot of publications looking at this. So more to come, I suppose, how it can, change practice, change guidelines.
All right, and a question from Dr. Barbara Casper, our former internal medicine chief. She says, excellent talk. Can you comment on costs for low-income patients? They may not be able to afford even a copay for meds, and coronary artery scores are not covered by insurance.
The coronary calcium scores are increasingly covered by insurance, much more now than they used to be, because now they're in the guidelines. They're in the US guidelines as a 2A indication, and their European guidelines. And now I would say I get about 80% of my patients, or 90% can get their coronary calcium score covered by insurance. I just write the indication like the guidelines, risk uncertain for a statin, and I write it all out. And so more and more insurances are covering it now. It's not like it was 5-10 years ago. But, even out of pocket, we can get them here with American Radiology about $100. But they try. Most insurance companies cover them now. In terms of other costs, so certainly statins and ezetimibe are generic. There is some cost with PCSK9 inhibitors. But, if they have the appropriate indication, we work with our specialty pharmacy and we're able to now I have much easier time getting PCSK9 inhibitors covered than I did a number of years ago, as long as they meet the indication. The pre-auth has gotten so much easier for PCSK9 inhibitors, and I have several very low income patients with FH that we've been able to get them on PCSK9 inhibitors through these programs.
All right, and one more question from the chat area. This is from Dr. Amrout Kar from our environmental medicine division. Says latest data shows that apolipoproteins quantity are a better marker for MI risk, independent of LDL or cholesterol. What are your thoughts?
Yeah, so I think ApoB is important. I mean, 90% of ApoB is LDL. So, I certainly kind of start with LDL, but once I think that people might be at the goal that I want, I think it's reasonable to check ApoB. ApoB is capturing all the atherogenic dyslipidemia particles, including the triglyceride-rich lipoprotein particles that I also mentioned are elevate risk. So it's capturing those plus LDL. So it is a potent marker, and many guidelines, the Canadian guidelines and other guidelines have incorporated ApoB into guidelines as a secondary target. In the U.S. guidelines, it's listed as a risk enhancer, but in other guidelines, it's actually a target of therapy, a secondary target after LDL.
And that's all from the chat. Now, maybe does Dr. Gavgazi, did you have a question?
Yes, a couple of quick questions. So in Cardia study, which is one of these epidemiological studies, 25% of patients with diabetes had no calcium score. So do you ever use a coronary calcium score in patients with diabetes? Or because the guidelines say you have diabetes 40 to 75, start statin. But maybe they can be, at least in motivated patients, a nuanced approach. Wanted you to comment on that. And then I would love to see another EPA randomized trial. Are you aware of that happening? Because that question still, even though those explanations are good explanations, but I guess the question still stands. It would be so. I'd like to know if you are aware of another trial that's going to maybe settle that question for good. Thank you.
Yeah, so I'm not aware of another large outcome trial with a different comparator. I agree it'd be nice to have. I'm not aware, trials are very expensive and they have the FDA approval, so I'm not really sure that I'm not aware of that going on. But in terms of the other comment, so yes, so diabetes, I agree, is a very heterogeneous condition. So it's not everybody with diabetes is CAD risk equivalent, and even among patients with diabetes, there's low risk groups. So data from MESA as well as Cardia have shown that a patient with diabetes with a 0 calcium score actually has a similar risk to a patient without diabetes with a 0 calcium score. So there are some patients with diabetes who I think are otherwise lower risk. They don't have hypertension or family history or other risk factors. And maybe for whatever reason, they're statin intolerant or reluctant to start a statin. I have used a coronary calcium score to help further refine risk to guide shared decision making when it was unclear. So I don't do it in every patient with diabetes. I generally just treat because statins are cheap and effective and safe. But I have used it in some patients because I do agree with the comment that a 0 calcium score does identify a lower risk subgroup of patients with diabetes.
All right,
great. Well, thank you, everyone.
Yeah, thank you, Dr. Michos. This is outstanding. And Dr. Kalra, we've got a little presentation for Dr. Michos while she's here.
Yeah, so that was a very comprehensive and very useful talk for our audience. And in keeping with the UofL tradition, we like to give all of our speakers a Louisville Slugger bat. So we will be sending one of those to you. There, Jason's got one in his hand. So
Yeah.
as a token of our appreciation, and we hope you'll come back next year and give us another update next year. So thank you, Erin.
Oh, thank you so much for having me, and everyone's staying on late. So much questions about lipids. I love it. So
Thank you so much.
bye.
Okay.
Thank
Bye,
you, Dr.
everyone.
Michos.
Thank you. Bye.
Yeah, we'll see everybody, and thank you, Dr. Michos, for outstanding presentation, and as we always say, pertinent and timely. So we really appreciate
Okay.
Dr. Kalra. Thank you for making the invitation, and this is really great. And just want to remind everybody, next week is Thanksgiving, so we will not have grand rounds. We will be returning 8 a.m. Thursday, December 2nd, and I'll be in touch, Dr. Kruger, because it's actually going to be it will be a gastroenterology presenting. So again, thank you everyone. Thank you, Dr. Kalra. Thank you, Dr. Michos. Thank you to everyone that joined us, and great questions and great interaction. And it was another great talk.
Thank you.
Thank you. And again, we'll see everybody on that's December 2nd. As always, Thursday at 8 a.m. So thanks again, everybody, and everybody have a great Thanksgiving week, and we'll see you in a couple of weeks.